12, now it's 13 years ago, I made this PowerPoint slide. It's one of the earliest PowerPoint slides ever made. Do not do breast biopsies on Fridays. Now, why would you not want to do breast biopsies on Fridays? Well, a lot of laboratories do not bring staff in over the weekend to process the tissue. Put it right through the tissue processor so it doesn't overfix, get it right through everything, the dehydration and the embedding. So it protects the biomarkers so you'll get an accurate reading. Because if you don't and leave it there all weekend, you got over 72 hours of unopposed fixation, which can alter the results of tests like the estrogen receptor assay. And if you can't pay or arrange for your staff to come in and process the tissue on the weekends, then tell the surgeons, don't biopsy on Fridays, only on Thursdays, where we can do it over the night on Thursday and it won't be a problem. I thought I was kind of out in the wilderness with this idea, but last year, a group from the Intermountain States, which I think used the LDS hospital in Salt Lake City as the core testing laboratory, got interested in, actually they were interested in menstrual cycle timing and diurnal rhythms, so they wanted to look at when the patient's tissue was removed and whether they responded to tamoxifen or not. But what they ended up finding was, if the patient's breast tissue sample upon which the ER test was done was taken on Monday, Tuesday, Wednesday, or Thursday of the week, there was no statistical difference in what their response rate to tamoxifen was. But the patients on Fridays all had a lower tamoxifen response rate compared to the Monday to Thursday patients. My view being, in there are the false positive ERs from the over-the-weekend fixation, leading to patients who would have been ER negative if they'd been biopsied onto Monday, Tuesday, Wednesday, or Thursday, getting biopsied on Friday and being called ER positive, getting treated, and not responding. So just a simple thing like how long it's in formalin has a pretty significant impact on the test results. One of my other favorite pre-analytical comments is, if you remove a breast cancer specimen in the operating room or in the radiology suite and don't put it into the formaldehyde fast and let it sit at room temperature for a number of minutes, each minute it's out of the patient but not in the fixative, the mitotic figures finish and two cells form. But because of the anoxia, no new mitoses start. So you end up getting a false low mitosis count. And for my medical oncology colleagues here, anytime you get a path report from a pathologist in which they give you a Bloom-Richardson intermediate grade 2, but it's 3 plus 3 plus 1, it's probably high grade, if the 1 is mitosis count. Because what happens is you probably got a late fixation specimen, because when you have a solid tumor with a high nuclear anaplasia, you usually should see some mitoses. So what I do in those cases is use the Ki-67 proliferation marker. I'm using a 20% cutoff. If I get a 3 plus 3 plus 1, I've called it 3 for solid pattern, I've called it 3 for nuclear pleomorphism, and then I look and I can't find any mitoses. If my Ki-67 index on the same block is greater than 20%, I use it as a surrogate for mitosis counting, and I write a note saying, although Bloom-Richardson would say this is intermediate grade, I believe it's high grade. And I know it's important, and it's been validated, I might get to it at the very end, on transcriptional profiling. When you profile on microarray the genes expressed by grade 1 Bloom-Richardson, those tumors all show a similar gene expression pattern. Same for grade 3. But when you profile morphologic grade 2s, half of them profile and will cluster with the grade 1s, the other half cluster with the grade 3s. Meaning the gene expression profiling, or the so-called genomic grade index, which has been commercialized by Ipsogen, is clearly a dichotomous differentiation. There's only 2 grades of breast cancer, really, low and high. And that's probably true of every other cancer. Prostate, colon, lung, there's probably only 2 grades. All these years we've been making, and even the Gleason system, it's probably low grade and high grade. And of course, as pathologists, we put all these 7s out there, which says, might be either. So I'm using the Ki-67 to try to get my grade 2s to match better the Soteriou molecular grading and getting some of my 2s up into 3. And I know it's important because medical oncologists, I'm aware, are very sensitive to grade. And in the era even before Oncotype, if you had a node-negative, ER-positive small tumor, and you were thinking tamoxifen alone, but my path report said high grade, Medical oncologists don't like to leave high-grade breast cancers uncovered by cytotoxic adjuvant chemotherapy. They see high-grade, they immediately say, this worries. This is a predictor of possible bad outcome. I don't care how small it is. I don't care that it's ER positive. I don't care that the nodes are negative. I want you to take cytotoxic. So I don't want my 3+3+1s to be thought of as just intermediate. I'm afraid they're more serious than that. And the fact I can't find the mitosis is an artifact, not biology. And I wanted to emphasize that. So let's go on to something else here.